we're going to start. Okay. So thank you, everyone, for coming. I'm really excited about today's panel. And first, I'm going to introduce myself. I'll let the panelists introduce themselves. I'm Georgia Guevaras. I'm the co-founder and chief medical officer at Talkiatry, which is a nationwide telepsychiatry practice. I'll talk a little bit more about us later when in context of what everyone's doing. But today we are here to talk about partners in mind, navigating the world of behavioral health partnerships. I'm also of a generation that I like paper, so I'm going to have these in my lap, if that's okay with everyone. So over the last decade, we've seen an explosion of demand for behavioral health services. I'd argue probably longer than that. But we do see, and we've all seen the statistics about the need for behavioral health services. And today we're going to talk about access to those services. And we know that access is a challenge. So some people can wait 45, 50 days for an appointment with a psychiatrist. And we've all seen different studies, different statistics, but about 1/3 of Americans don't live within an hour's drive of a psychiatrist, which is pretty staggering. We have wonderful healthcare institutions in America, but even they have trouble getting access to psychiatrists for their patients. So there was an article in the Washington Post, I'm sure you've seen, about one of our top health systems in America, where the wait list for mental health referrals was so long, it was over 800 patients, I believe, that administrators just told people to stop referring. And as a psychiatrist, to me, that's just terrifying, that there are people that need services, and they're just told, don't even refer anymore. So another thing we all know is that when a person has both psychiatric and physical comorbidities, they are, untreated mental illness can make that physical comorbidity that much worse. So not only does it make it worse for the person, obviously the experience, but costs go up, hospitalizations go up, emergency room visits go up, and those are all things that obviously are a burden on many, many levels. So we're here to explore how behavioral health partnerships can help ease that burden. I'm going to let everyone introduce themselves on our panel before we get into some discussion, and then hopefully at the end some time for questions from you guys. There's a QR code up there if you want to submit to my handy-dandy iPad here, or we'll just use the mics old school. So go ahead, Howard.
So my name is Howard Weeks. I'm a psychiatrist, and I'm the Chief Medical Officer for Eating Recovery Center and Pathlight Mood and Anxiety. We provide some specialized services for patients with eating disorders, as well as patients. We have a division that focuses on mood and anxiety, and we're in what I call the intermediate space. There's inpatient and there's traditional outpatient, and we're providing services for those patients that need residential level of care, partial hospitalization, or intensive outpatient level of care. So we fulfill a niche in the mental health continuum, but we need partners from a higher acuity level, and then also as patients move to kind of an outpatient standpoint. So we'll be able to talk a little bit about why partnerships are so important there.
So I'm Andrea Anderson, Vice President of Population Health and Quality with Millennium Physician Group. We are predominantly primary care group practice based out of Florida. We're throughout the state of Florida. We also have a couple of practices in North Carolina and also in Texas. But as I said, we're primarily primary care. We have over 650,000 lives that we cover. 200,000 of those are in value-based 100% full risk arrangements. And so we've also partnered to assist us in managing a component of the care that we need for our patients.
Hello everyone, my name is Kfir. Super excited to be here today. I'm the GM of BetterHelp Business, part of BetterHelp as a company. We're the B2B section of BetterHelp. If BetterHelp hopefully doesn't, but if it needs any introduction, we're the world's largest online therapy provider with 35,000 therapists nationwide, readily available to be matched with members in America and worldwide. BetterHelp Business is really taking all the good stuff that is BetterHelp, the largest network, the member adoption for our services, the brand awareness, and really wrapping it into a comprehensive program for really any type and any size of an organization that is looking for the right care for their members. Thank you.
I'm Andrew Rubin. I'm the Senior Vice President of Clinical Affairs for NYU Langone Health in New York. Clinical Affairs basically means I run the provider network, the physician group, which is 5,000 providers, about 4,100 MDs, of which 200 are currently psychiatrists.
Great. So before we delve too deep into how the partnerships have worked, I think it's important to understand the challenges presented when the needs go unaddressed. So basically, there's lots of different agencies and oversights that require screenings. We know Medicare screenings for depression, primary care visits for screening for depression and anxiety. And then a lot of PCPs say, I've screened my patient, they need a referral. I can't do it. Where do I go? What do I do? So I think that it's important when those needs present themselves in the system to address them and to address the stress that goes along with it. So Andrew, maybe we start with you. NYU, obviously a huge institution, multi-specialty. How do you see those needs present themselves, and how, more specifically, maybe you can talk about how Talkiatry has helped, that partnership with Talkiatry has helped specifically with those needs?
Sure. We have, as I just mentioned, we have a very large physician group. We run out of about 350 locations. Our psychiatry network is predominantly based on the main campus. Of course, we have a huge teaching program with Bellevue, for those of you who are psychiatrists and know the industry. But our ambulatory mental health program, struggled immensely. We essentially have, as I'm sure many of you know, limited supply, unlimited demand. So it wouldn't matter if we could hire 200 more psychiatrists. We'd fill them up the next day. Just because our provider network is so large, so many people need the services. And quite frankly, the larger the network goes for a big academic healthcare system like ours, the harder the economics become. For us, being able to provide mental health services is something we lose money on, basically. So we have to balance the ability to provide mental health services for our patients at the same time not losing too much money, because we're not for profit. So I think it was by just luck I met the Talkiatry people, and I happened to work for a physician who is a psychiatrist. He's the vice dean and executive vice president of the health system, and we got together and just talked about what Talkiatry was doing a couple of years ago, because we saw that there would be a really easy, seamless way for our providers to be able to connect with quality psychiatrists online, so that anytime one of our providers had a mental health referral, with the push of a button, they could send that information over to Talkiatry and the patients could get scheduled. And it's been extraordinarily successful. One of the items I forgot to mention, which is important, in our mental health network, in our group, it's all self-pay. So the only employees whose insurances we bill, the only people whose insurances we bill is for our employees. So even if we had capacity, the ability for all of our patients to be able to see a psychiatrist would be limited by the fact that they would have to pay out of pocket. So when we found Talkiatry with this sort of integrated, seamless way to be able to connect our patients to mental health providers, we checked out their quality, obviously. They're in the networks of many of the large plans. It really turned out to be a home run for us. And the feedback we're getting, candidly, is very positive, more from the doctors than anybody else, because they had nowhere to go. They had patients who needed help, and they couldn't send them to us, their own group. And Talkiatry's really filled that need for us.
Yeah, and I hear a lot from doctors that are happy that they're able to refer a network, because that's a big thing when your PCP's in network, to refer out of network for specialty care. It's always a challenge. And I think you brought up something really important that, Howard, I'd love you to talk about. When we talk about building these networks, there's the build versus buy proposition. Do we go out and partner, or do we build it ourselves? Right? So for you and your team, can you talk a little bit about the partnership and how you make that decision for your levels of care and integrating Talkiatry?
So I think that's a really important thing when you think about for like a large integrated academic medical center versus like where we're in the position of we're in 7 states physically with brick and mortar and about another 14 states from a virtual component for some of our programs. So it's hard when I think about, well, how do I make referrals when people are ready to step out? Some patients, in the old days when we were founded like 15 years ago, patients that came to us all had an outpatient psychiatrist and all had an outpatient therapist. So we were just sending them back to those same providers. We provided that kind of higher level of care and they went home. Well, as mental health, while still stigmatized, has become less stigmatized, we're seeing a lot more patients getting access and starting to come into mental health care. A lot of them don't have psychiatrists, don't have therapists. Sometimes they have a primary care provider who's trying to provide all the mental health services. But as you get into that more specialized level, you run into some real issues of, it's not just even competency, it's time, because mental health services, especially in large centers, can be a money-losing proposition. So I don't want my primary care doctors taking care of psychiatric services. I really want to specialize and send them to the psychiatrist or the therapist. So for us, what we started to realize was we had a lot of patients that came into our system where we stabilized them and made a lot of progress, and then we're trying to send them back out, and we didn't have providers for them to go see. Now, we do have a small ambulatory practice, but it's very small and very localized. And for us, it was trying to figure out, we were struggling, we were hearing from our docs and our therapists, we're about to send this patient out, and we don't, where they live locally, there's not a provider. So finding a partner that was national, that had quality that matched what, from our standpoint of we think about outcomes and we want to know that we're sending people to someone's going to take good care of them was very important. So we partner with a lot of people, but in particular with Talkiatry, the idea is to say this is a partner that we feel very comfortable referring our patients to if they don't have a provider, or if over time their provider says, hey, this level of care for this particular patient isn't something we can handle, we want to be able to refer them to someone that they can continue to get that care. And then worst case is they might have to come back to us, but we really don't want that. So we want a partner that we can kind of continue to iterate with to keep people out of our system.
Yeah. I think that's obviously super important. And I want to talk a little bit now, Andrea, maybe you can address this at Millennium, which is a value-based care company and a group, and you have to consider patients holistically. So, for example, the comorbid mental health and social determinants of health that exacerbate the underlying physical health conditions. So it's challenging across every facet of care delivery. I mean, we're not telling anyone anything they don't know. So how does the need to provide these timely solutions across that wide range change, the calculus of whether you build versus you partner?
So, as I mentioned, we're predominantly primary care. So it's pretty easy to look at what we need for specialty care. So cardiology, recruiting that, recruiting endo, recruiting GI. But that mental health space, we've struggled over time. One was even just finding enough providers that we could recruit and bring into the fold, and then having the capacity to cover on a statewide for our patient population. It was always a space that we struggled in. And we had patients that, similar to what you described, we had patients who were waiting for months to getting in. But we knew that it was a space that we had a significant gap. And we had patients who were quite honestly affected by their mental health components, which was affecting their physical health. So patients who are bipolar, schizophrenic, depressed, or have anxiety who are not taking their medications, and that's definitely affecting their med adherence, it's affecting their diabetes, their heart failure, they're showing up in the ED more frequently, and then being hospitalized. So we knew it was a significant gap, and similar to what you described, Andrew, I happened upon Talkiatry at a conference, and was talking to a peer who had started working with you guys and had found great success. So once we talked to you guys and had the conversation, I had several of the medical directors to meet with your leadership team, your clinical team, and verbalize what we were looking for, and that you guys were able to meet that. It really was a no-brainer. But our providers have been so overwhelmingly happy that we're now able, because they struggle, and when you have patients that present and they felt quite often that their hands were tied because we had patients who were in crisis or patients who needed had long-term needs, and they weren't able to fulfill those and handle those. So that social determinant space has always been a challenge, and you guys are definitely helping us to fill that gap.
Great, thank you. So I think we're all sold on there's a need to partner. I wanted to, there are a lot of companies that are offering solutions in this space. Some of them are here in the audience or certainly here at the conference. And there's so many criteria to consider, quality, access, implementation, coverage, geographic footprint, ongoing support. So you have to evaluate, well, how are we going to think about this? How are we going to evaluate with whom we're going to partner? So Kfir, maybe I want to talk to you a little bit about BetterHelp Business, and you're building a product to provide employers with broad access to mental health resources. So when an employer is assessing BetterHelp Business, what are they looking for, and how have the needs of the employer market changed over the past 5, 10, I would say even 15 years at this point?
Thank you, Georgia. Before I answer the question, I'd like to kind of address a point you just made about having so many companies and solutions, selling mental health solutions into the mainly employer market, but just in general. And don't get me wrong, I'm all for competition. In fact, we're all in a line of business where if you have, or most of us, if you have competitors, it only means that more people are being helped, which is great. But my issue with that is actually the perception of all things. Sorry, and I'll give you a quick example. So much like I'm sure yourself, Georgia, and many friends here on the panel and in the audience, I attend a lot of mental health conferences and events within our industry. And when I do that, I like to roam the exhibit hall and look at all the vendors and the booths. They become more and more beautiful every year. And my main goal when doing so is really to come back home with the fuzziest swag for my daughter. But aside of that, also to get myself a little bit familiar with what else is out there, what's coming out. This is, after all, a panel about partnerships, so opportunities to partner and provide a more well-rounded offering altogether. So this is a true story. I approached one of the booths in a conference, and much like everybody else, their backdrop is plastered with mental health and therapy and so on and so forth. And just a fact, I wear my BetterHelp t-shirt everywhere I go, so it's not like I'm spying on them or trying to fool anyone. And then I asked the guy behind the table, I say, hey, I see that you all do therapy and mental health. He said, yeah, of course, we do. And I tell him, well, that's great. Do you mind if I ask how many therapists you all have within your network? And the guy goes, 25. And honest to God, George, I'm waiting for them to finish the sentence, like 2,500 or maybe 25 in each and every state, whatever, just tell me something. But it's really 25. Now, don't get me wrong, I'm sure it's a great starting point, and they probably provide a valuable solution and have growth aspirations and solid plans to make their network more robust very soon. But to the naked eye or to the employer that is also roaming that exhibit hall, that creates a reality where it might seem like all solutions are equal, and that's where I'm going with this. So to answer the question, what employers should evaluate when they're looking into a mental health solution for their organization, I want to bring it down to 3 check boxes, if you may. First and foremost, accessibility, and we talked about accessibility, previous questions, I think it was my friend here. This is probably the few cases where size does matter, because it's not just the number of therapists you have in your network that you can show off, but rather it immediately translates to everything else that matters in our industry. So time to be matched, the quality of the matches that you do to therapists, the fact that you can offer choice and diversity. So for example, within our 35,000 therapists, over a third self-identifies as BIPOC, which is helpful for us to make a good match overall, and it's important for our members when we match them. And also other factors, such as the first available appointment and the quality of your matches and so on and so forth. The last thing you want is for a member's first, before we go to that, on the accessibility, on the product side of accessibility, you also want to make it as easy as possible for members to engage with the benefit. We all know that many people take a lot of time to build up the courage to seek help, to make that first phone call, to make that first step into their journey in their mental health. For many, that's never going to happen. A lot of people, unfortunately, don't make that step. But for those that are ready to make the step, you want to make it very simple for them to engage and have that be accessible, literally by giving them a link to click to get started, or a QR code to scan so that they can get started with the benefit, versus asking them to call, I don't know, an 800 number and speak to a complete stranger about their things that they're coping with and their issues and their secrets and whatever the case may be, only to be redirected to, by the care navigator to a clinician, to the source of care that they're looking for. We all know that having to talk to someone to be redirected to care is actually more of a blocker to get care versus to actually get care. So that's on the accessibility side. The second one would be availability. So hopefully you were able to match them to a therapist. But what's the availability of that therapist from that moment on? The most frequent question we hear from employers in our many conversations throughout the year is, how quickly can my members see a therapist? So if they want to get the care, the help, how quickly can they see a therapist? Will that therapist be able to see them tomorrow? Or and I heard you saying like crazy numbers of days that, with psychiatry, and I hope I know you all are doing a better job in taking care of that. But would that therapist be able to see them tomorrow, or would they have to wait like 5 days or a week or longer to have an appointment? And the last thing you want to have on as a member's experience is to have the member's first interaction with your app or solution to be looking for that switch provider button because they weren't able to find a slot that is either soon enough or, speaking of choice, being accommodating of their special needs and wishes. Maybe it's a late night session. Maybe it's altogether a session over the weekend. So that's on the availability side. And lastly, the third component would be, or the third checklist should be, dependability. Going back to that employer that is roaming the exhibit hall with me, thinking that all solutions are equal, that often leads to making decisions based on either predominantly or solely on pricing. And, sorry. In the last couple of years, well, first of all, we can all agree that everybody can slice up their prices in hopes of winning a big contract or winning an RFP that they're bidding on. But really, in the last couple of years, we saw a lot of companies disappear as soon as they rose, following the overwhelming demand that was triggered by COVID for all of us in the last couple of years. And the last thing employers want to do, employers want to provide solutions to their employees, not problems. So in looking into dependability in a provider, you would want to go with a provider that has demonstrated successfully delivering quality of care at scale for a long period of time, but also some level of reassurance that they're going to be here tomorrow no matter what comes.
I think this is a good spot actually to talk a little bit for the entire panel. What goes into that decision on with whom you're going to partner? Because there's an interest, there's a need, but when it comes to the actual decision, there might be the mutual interest, but there's so many competing priorities, there's so many things that go into it. So when you're considering that partnership, a lot of people here are probably wondering how do they have a successful meeting to create one of these partnerships. So maybe you can talk a little bit about your experience with Talkiatry and how we got to yes, if you will.
I just want to go back because I thought Kfir made some good points. In the healthcare space, so much of the talk is directed, and I don't mean mental health care. I mean healthcare investor-backed space is about going to employers. So you have, whether it be IVF or menopause or doulas, whatever clinical service is being marketed towards employers. I think mental health is in a space all of its own. The fact that so much of healthcare is now delivered through online telehealth is been explosive, creates explosive opportunities for mental health providers. But I think a lot of these companies fail because they're going to employers. They're offering a service that is definitely helpful, but employees tend to not want to get health care through their employer. I know that that people believe that that's where the market is. I actually don't believe that. I believe that healthcare is best delivered through healthcare providers, and physicians of all specialties are uniquely positioned to be able to identify a patient who's in distress or who would benefit from a healthcare service. So any mental health provider, talkiatry in particular, is uniquely positioned to have that relationship. So I think it's important for everyone who's participating in these conferences and who's involved in this industry to, best figure out who the clinical partner is. Is it an employer? Is it a health system? Is it a medical group? Is it a long-term care facility? Because I think that's really the sweet spot for this industry in this particular lane. In terms of how you evaluate the quality that's going to come out, well, I think certainly in the case of talkiatry, you were by the time I found you, you were established and you were large enough. So we knew you weren't going away. But to your point, we've been approached endlessly, 25, 50 provider groups. It just won't work. So I think scalability, size is level one. And then truthfully, you never really know until you're actually working together. Who are we checked out the providers, your credentials of who you're hiring and making sure that you're hiring, quality mental health providers, but you don't really know until you know. And then honestly, if it didn't work, we'd stop. If the feedback from our patients was bad, because we solicit their feedback, if the feedback from the providers were bad. So that's sort of how we've been able to do it. And it's kind of like that with any physician. You could be the best trained physician in the world and be a disaster in practice. So you just have to, it's a little bit of a, roll the dice and hope that you pick the right provider, the right partner.
Well, and I think for us, when we think about forming a partnership, it's the initial conversations, but then it's understanding how that particular company is ensuring quality and what kind of program they have. And so like the discussions we had with you, you came saying, well, here's our outcomes. And I could see the process that was already there in place. So while I'm going to do the same thing as surveying my patients and surveying my providers, I also have a confidence that that partner is already doing that internally. And in fact, I felt when we were first talking, that was the exact question you were asking us. It's like you wanted to know, well, what's your quality? What's your process to make sure that you're actually improving things for patients? So that made it a very philosophically aligned. And then you get into the discussions about, well, how are you going to communicate? It's one thing if I'm in one system and I have my own providers and I'm on the same EHR, but now as you're really talking about partnerships, you're not. And so you're having to figure out, how do I get my IT systems to talk to each other to make it as seamless as possible so that we can communicate well and effectively. But I also want my providers to pick up the phone and talk to other providers. I mean, so I want information to flow, but I also want that touch, when appropriate, that providers can talk to each other. And is that something that's available? So for us, that's important. And we need to always kind of look towards our partnerships to say, are we aligned in that sense of what's the care that we're going to be delivering and how we're going to do it? And then can we identify whatever those problems, because there's always problems that show up, how do we have a process to tackle those and to try to solve them in an efficient manner?
I still remember our conversation, actually. It was, we talked for a while. And it's all, doctors, when we get in the room, we can chat forever. So, Andre, I know you were going to say something as well.
Yes, as we looked at you guys as a provider, we were also looking at who understands what we're doing here. We're all about evidence-based practice of medicine and improving patient outcomes. So it was very important that you understood our ultimate goal for our patient population. Also, with primary care, I have patients who are 5 or 6 years old up to the 100 plus. So I needed a provider that would I needed a provider group that would understand the needs of that mother who's trying to manage whatever's going on with her kids, as well as that daughter who's trying to manage whatever is going on with her elderly parent. And so having providers who were open to that, understood that, were able to show us the evidence that they've looked at those components as well and have the outcomes to show improvements in PHQ-9s and the actual details, and open to sharing that with your partner. That was the other component. The other thing is we use a particular EHR, and I won't name a name, but we use a particular EHR, but it was very important for my providers to know what was going on with their patients. So we wanted to be able to close the loop, and you were able to coordinate with our IT team to bring that information back to the provider. So not only do they know that their patient has an appointment within the next 3 to 4 days, but they know what happened during that appointment in an appropriate manner for a behavioral health note. And they know as subsequent visits happen, what's going on. So when Ms. Jones comes back in, they're able to have that dialogue and have that conversation about what went on in their psychiatry visit, ask any questions, elaborate, and discuss the improvement as far as outcomes for that particular patient.
I think that also, shows that it's not just the provider experience or the patient experience. It's a good experience for both, because as a patient, it's great to go in and your doctor already knows. And as a doctor, it's great to already know what happened with the other doc. Yeah.
Absolutely. And in my situation, I have the case management team. So it's important for my nurses who are talking to those patients every week, every 2 weeks, every month, to be able to have those conversations with them, or even their caregivers, that they had that appointment with their mental health provider as well.
Great. I think
I think it also depends on the relationship you have. So going back to both your comments, one on the tech side, passing information through, and then clinical back to the providers. Even within our own psychiatric network, we use Epic. Our psychiatric notes are locked down. So the primary care, the cardiologist, who's ever referring that patient for mental health, or if they're self-referred or something, the physician network does not see anything related to that patient's mental health record, even if they're our own provider network, which is, so for us, passing through clinical information wasn't as important. Even medications, the patient would have to self-identify when they go see their provider that they're taking those medications, because we have a solid wall between us.
Yeah, super important, especially since patients don't always know, which is, as doctors, sometimes we find shocking, but it's true. I think I want to leave some time for questions, but I think it's also one last thing I'd like the panel to maybe talk a little bit about is, it's great. We create the partnership. I think among us, we represent thousands of clinicians. How do you actually get that information to your clinicians? What's the best way to let people know at NYU, at ARC, that this exists and that this is now it can be part of their workflow and make their referral to behavioral health easier?
Well, we have a number of different communication channels, and so we have monthly meetings with our providers, so that's one mechanism. We also, of course, have email communication, but we know how many of our docs read their emails every day, so, but their managers get that same information, and so we share that with them. Actually, this month, all of those provider meetings are in person, and so the psychiatry representative will be there to share that information. But the other component that I think is critical is we integrated it in their workflow. So they're able to see it in their EHR, they point, they click, and that referral goes over to you guys and you take it from there. So I think making it easy and then communicating that it was there was critical for our team, for the success for our patients.
We struggle with it just because we are our own brand and our own network of physicians. So, as I think you know more than anyone, being able to label our psychiatric services as psychiatry just can't happen. So it really is just, we push the information out to the provider network. We remind them constantly. We talk about it at our monthly administrator meetings where our whole network of management gets together. And honestly, I think now we're starting to get traction with patients who talk to each other. Where do you get your where do you get your health care from? And word of mouth is really, within our own network, is taken off amongst the providers and the patients.
I think one of the biggest marketing tools for you guys is your patients. Because when your patients come back and tell their provider that they have had a positive experience, then that provider is more likely to refer to you guys over and over again.
Well, and I think that gets to a key thing that I think is very true in a lot of medicine is you can advertise, you can talk about things, but oftentimes it's clinician referring to clinician and saying, well, I know this group or I know this particular provider. And while I may not know every clinician in psychiatry, I can say I know this company and I feel very comfortable making that referral. So we do a lot of, obviously talking to all our physicians, talking to our therapists, talking to our care coordinators. We track that because we have metrics as we think about discharges. I mean, we're not a large academic medical center. I have 1,500, 1,600 patients in my system in a given day, and eventually they're going to discharge, but I can track that. I look at their aftercare plan, so I can know where they're getting referred to. And we hear like, hey, we're having struggles finding these patients, and then we go out and do extra education to say, okay, if you're having trouble finding a referring provider, here's some of our partnerships, and let's remind you of that. And we build it into the EHR where we can. Some of this is a work in progress depending on your EHR, right? Yeah, so it's always a continual iteration to try to make it better, to reduce kind of those pain points.
I'm sure there's a lot of EHR opinions in this room and at this conference, so I'm not saying anything people can't relate to.
I just want to add to that if I can. For us, and I'm actually answering also the previous question in the same time, for us saying yes to psychiatry was the easiest no-brainer because it's literally the most logical, natural next level of care that we can offer to our members right after talk therapy, right? I mean, and in fact, and to go back to this question and echoing Andrea's comment about having multiple channels, we didn't just use all the channels that we have with our provider network to make them aware of this additional layer of care that is now available to members. But because of how this was a natural growth of our value add and literally product, we made it part of the product. So now when a therapist on our network has a session with one of the members, within the dashboard that the therapists have, they literally have like a visual indication that this member also have access through their employer group, bless you, to psychiatry services and medication management through psychiatry, so that if they feel like this could benefit the member from a clinical standpoint within their journey, they can make that referral and make them aware that they have this available for them as within their account, and that's a simple click for the member to click and get to psychiatry, so that so they're not just making the member aware, but also guiding them how to take advantage of this. And as they come back for the next session or the following session, they can, kind of have a consortium of, the care that they're getting at the second floor of our house, and keeping everything within the platform.
So we talked a lot about how our current partnerships work well. It's a very specific type of patient that we're talking about. But as we look towards the future, I think the last couple of minutes, maybe you guys can talk a little bit about where there are still holes, if you will, in your institutions for what needs in behavioral health are still lacking, and what kind of your wishes for that. What would you think would be helpful if there is anything that...
I think our biggest hole for us is that patient in crisis. That patient that needs management today. That patient that we're sending to the ER because they're suicidal, or they're on the phone with one of my case managers, and we need to involve emergency services. So that's really the biggest gap, I think, for us right now. But you guys have filled the others, so thank you very much. But if you want to fill that other gap, thank you. We look forward to partnering with you on that.
Listen, I was an ER doc for many, many years, so I'm happy to look at that in the future. It's something actually Robert and I talk a lot about. It's close to my heart, so stay tuned. Andrew?
I think our biggest challenge is 60% of our patients are governmental payers. And who knows what's going to happen, going forward with the payer system in terms of exchange plans. And I think there's still huge holes, even in the psychiatry-like companies out there for being able to. So we can only, you're helping us immensely with a huge need, but I think the need is much greater than the network of patients that we're even sending to.
I think that the supply is endless for patients. I don't think that's...
Yeah, and it's payer, right now it's payer driven, so we got to get all the payers engaged in this, and for them to understand and recognize, the value, yes, you might have to pay more to get a mental health care network developed, but the savings on hospitalization, other healthcare crises that, evolve from not treating mental health conditions, I got to believe can save the healthcare system quite a bit of money.
Absolutely.
I mean, we see...
Yeah, go ahead.
Oh, go ahead.
No, you first.
So we see a lot of gaps also when I think about specialized care close to home. I mean, we're kind of in a niche subspecialty in psychiatry, and we partner with our other direct competitors all the time because we know that sometimes we're a good fit for a particular patient, sometimes we're not, and they're a better fit. But yet we still all struggle as an industry to say we don't have enough for those patients that need that higher level, that brick and mortar kind of interaction. There's a lot of patients we can treat virtually, but there's also a lot that we can't when they need higher levels of care, and we don't have enough access across the country for that. So that's a huge need, that we need more providers localized, and we've done so much better about getting out and filling some of the gaps by using telemedicine and telepsychiatry, but the need is so strong, and some of that is still years away from being fixed.
Yeah, for sure. I mean, Andrew's in Manhattan, right? And you'd think you throw a rock, you hit a psychiatrist, you'd think it'd be easier, and it's so hard. And then there's places like Utah or Colorado where it's just impossible. And I think, what's the statistic? 60% of counties don't have a psychiatrist.
Yes.
So yeah, it's definitely a constrained resource. Kafir, I know you wanted to say something?
Yeah, I was about to say that maybe not as much a challenge, but rather an opportunity. But having doing this for over a decade, we realized that everyone's journey with mental health is different, and as such, support should be the same. So our partnership with psychiatry is the first step of stepping out of offering just mental health, right? And we're currently evaluating other additional services that have same fit to our mission in helping more people with their challenges that they might be coping with. Realizing, so for example, we're going to be adding stuff like nutrition and caregiving and neurodivergence and other benefits or well-being components to our overall offering, realizing that for many, talk therapy might not at all be the door that will get them in. So that helps us to cast a wider net and help a larger addressable market altogether.
We have about 2 minutes. So if anyone has any questions that they want to ask live, this is your chance. Yeah, please. If you can get to a mic, otherwise be real loud. Oh, thank you, Andrew.
So I appreciate you asking the question about the gaps still in the services. So I represent the most severely mentally ill. That's what Arizona Mad Moms does, kind of the unspoken. And I've watched, this is my third one in here that I've watched about partnerships and stuff. And I'm just wondering where the outreach is into the prisons, the homeless shelters, the individuals that have anosognosia, the ones that are difficult to treat, the ones we pulled out of the hospitals back in the 90s, because their levels are not improving. And I wondered what these partnerships can possibly do for a group like that.
That's a huge gap in our healthcare system across the country, because I struggle with that, where there are patients that we can't treat due to their diagnosis or their severity, and we're having to try to partner with our local mental health networks and try to refer those patients in, but there's just missing huge gaps. Some of it's funding, some of it is even expertise and ability to focus on those patients. And so we don't have a solution, but that's actually where we have to then start reaching out, like not only are we filling the gaps from an outpatient standpoint, but then locally at every one of our facilities, we're also working with the local mental health authority so that we can try in those times to refer to them, but sometimes they have capacity limits as well.
And there's also that synergy that needs to happen between, you can have the psychiatrist be telemedicine, but if it's a homeless individual, they don't have the tablet in front of them, right? So you need that on the, boots on the ground kind of service as well. That is very difficult. So I think that's where that hybrid, a hybrid solution makes much more sense. And also, these are individuals that may need long-acting injectable medications. We can't do that through telemedicine, but you do need that synergy with people that are boots on the ground. That's very difficult. I wish we had more time to talk about it. We could have our session just fully on that. But it's a very important question for sure.
I would love to see a future session on just that, because we have not had any in this conference at all.
It's a national problem, and it's lack of funding, and that's really what it boils down to.
It's lack of
Awareness,
concern,
funding,
care,
all of it. Yeah.
empathy.
There's a reason that not enough money goes to
Money.
certain things, yeah. And I mean, it is
Money.
money. I mean, these things are expensive. These are not. The medications are expensive. The care is expensive. These are things that do need funding. And Andrew's right. It's not there, and there are definitely changes that need to be made. There's no question.
Yeah, I'm just hoping we can move some money from some of these other things and adjust it to the people who really need it. Thank you.
Of course. We are actually out of time. We are around. You can see us. Stop by the Talk IG booth if you like. You guys all have access as well. So I want to thank everyone and enjoy the rest of the conference.